Multiple myeloma continues to occupy a major place in all hematology congresses. And this is exactly the case in this EHA 2019 Congress, where we do have at the Presidential Symposium in Myeloma communication about the superiority of daratumumab, bortezomib, thalidomide, dexamethasone combination in induction in the transplant-eligible patient compared to the traditional VTD. This is the so-called Cassiopeia trial. And I would like to take this opportunity to remind all of us that this induction story prior to auto-transplant in myeloma has been really fascinating. For more than 25 years, actually, we lived with VAD. Nothing could do better than VAD until we had the IFM 2005-01 trial, which was able to challenge the use of VAD and could show that VD, bortezomib dexamethasone, is superior in terms of response to VAD. So obviously, bortezomib became the backbone for induction. And how can you do better than VD? Well, you can try to add a third agent, either an IMiD, this is thalidomide, lenalidomide, VTD, VRD, or an alkylating agent like cyclophosphamide, and this is VCD. And VTD became extremely popular and was validated thanks at least to 3 randomized phase 3 trials. The IFM compared VTD to VCD, and VTD was shown to be slightly superior in terms of response, although the side effects, especially peripheral neuropathy, was superior with VTD compared to VCD. So triplet regimen combining an proteasome inhibitors and an IMiD like VTD, but also VRD, which is very popular in the United States in many places, and we know lenalidomide is highly effective in myeloma and has less toxicity compared to VTD. So the triplet regimens, VTD, VRD, VCD, became a sort of a standard of care for induction. And we've been living with this now for many, many years. I would say even like something like 10 years. So what is the next step? Well, adding a fourth agent, a quadruplet. And the most attractive agent these days is an antibody, a monoclonal antibody. And this is where daratumumab came into the scene, and the daratumumab VTD combination was tested in this Cassiopeia trial. And it showed that an induction with daratumumab VTD is significantly superior to VTD in terms of achieving stringent complete remission after consolidation, but also in terms of achieving more than CR, more than complete response. Also, you have a significantly higher incidence of MRD negativity tested at the 10-5 threshold. So VTD, now we move to DARA VTD as the validated induction. At this stage, I think it can be very tricky because people can be tempted to, by extrapolating the DARA VTD results into DARA VRD. And my best guess, it can work, and the trials are ongoing. But I believe the future is really very promising, because now you may wonder, why not replacing a first-generation proteasome inhibitor with a second-generation proteasome inhibitor like carfilzomib, and that can give you like DARA KRD, or ixazomib, which is an oral proteasome inhibitor, DARA IRD. And we should not forget that we have another monoclonal antibody, isatuximab, which has been tested in a randomized trial with VRD, IXA-VRD, and we are awaiting these results. I can even try to look into the long term, and after all, why not replacing lenalidomide or thalidomide by a novel generation IMiD? And these IMiDs are now being developed, and they have some very promising results in the relapse refractory setting. So the induction story is absolutely amazing, and I think the success in terms of induction will continue. And the story is not about whether we should get rid of transplant, in my opinion, but rather we continue to refine transplant by strengthening and optimizing the different components of the transplant, including induction.